everyone. We'll be talking about magnesium, its metabolism, biochemistry, and the reason for depletion in critical illness. Magnesium is the fourth most abundant element in the human body after calcium, potassium, and sodium. It is also the second most abundant cation within the body's cell after potassium. More than 99% of the total body magnesium is located in the intracellular space. 50 to 55% in the bone, 34 to 39% in skeletal muscles and organs, and less than 1 to 2% in blood and extracellular fluid. Magnesium within erythrocytes is 3 times higher than in plasma. This is why serum levels may not reflect the total body stores, and normal level of serum magnesium does not rule out deficiency. Normal magnesium level is around 0.75 to 0.95 millimoles per liter. The body's magnesium content is physiologically regulated through 3 mechanisms: intestinal absorption, renal reabsorption and excretion, and exchange from body pool of magnesium, that is through bones and muscles. Under normal condition, there is a balanced interplay between intestinal absorption and renal excretion. Intestinal absorption is influenced by dietary components like oxalates, phylates, insoluble fibers, increased level of zinc, iron, calcium, which all negatively impact the absorption of magnesium. Majority of magnesium is absorbed in the distal small intestine, and some amount is absorbed in the colon as well. Intestinal magnesium transport involves both paracellular and transcellular transport, where paracellular route is responsible for the bulk of absorbed magnesium. Renal elimination of magnesium increases when there is a surplus and can decrease up to just 1 milliequivalent of magnesium in urine during deficiencies. The proximal tubule absorbs around 15 to 20% of the filtered magnesium. This reabsorption is passive, paracellular, and dissociates from the reabsorption of sodium. The thick ascending limb of Henle is the major site of tubular reabsorption of magnesium, accounting for 50 to 60% of the filtered load. Distal convoluted tubule absorbs around 5 to 15%, and although the magnitude of magnesium absorbed here is relatively small, it is critical in maintaining magnesium homeostasis. Magnesium is involved in particularly every major metabolic and biochemical process within the cell and is responsible for numerous functions in the body. It is a cofactor for over 300 enzymatic reactions and is crucial for ATP stabilization and energy metabolism. It also plays an important role in bone development, neuromuscular functions, signaling pathways, RNA-DNA synthesis, cardiac membrane stability. In general, magnesium acts as a cofactor in all reactions involving utilization and transfer of ATP, including cellular response to growth factors and cell proliferation. Magnesium is necessary to correct structure and activity of DNA and RNA polymerases. Magnesium is essential for DNA replication, RNA transcription, and protein formation, being thus involved in the control of cell proliferation. Magnesium is also very crucial to maintain genomic and genetic stability and stabilizing the natural DNA conformation. Serum magnesium concentration are strongly related to bone metabolism. Bone surface magnesium is constantly exchanged with blood magnesium. Magnesium also induces osteoblast proliferation. Therefore, the consequence of magnesium deficiency are accelerated bone loss and decline in bone formation. Magnesium also participates in controlling the activity of some ionic channels in many tissues. Neuronal magnesium concentration downregulates the excitability of NMDA receptor, which is essential for excitatory synaptic transmission and neuronal plasticity in learning and memory. Coming to magnesium and electrolyte balance. Hypokalemia is a common finding in patients with hypomagnesemia. Potassium depletion in these cases cannot be resolved until magnesium is replaced. Multiple mechanisms due to which this occurs are magnesium effect on the ROMK channel, that is the renal outer medullary potassium channel. When there is an increased magnesium intracellularly, ROMK is blocked, which prevents potassium efflux. Therefore, when there is decreased magnesium, there is potassium efflux, and which causes hypokalemia. Other causes are sodium-potassium ATPase and sodium-potassium cotransporter. Hypocalcemia is also a common manifestation in hypomagnesemia, and it cannot be treated or corrected with calcium, vitamin D, or both. Magnesium therapy alone will resolve the hypocalcemia. Some factors which cause these are impaired secretion of parathyroid hormone and organ resistance to parathyroid hormone, increased metabolism of parathyroid hormone, and decrease in 1,25-dihydroxy vitamin D. Magnesium deficiency commonly occurs in critical illness and correlates with a higher mortality and worse clinical outcome. The cause for this decrease in magnesium can be GI loss. Both upper and lower GI loss can cause magnesium deficiency. Therefore, conditions like vomiting, NG suction, diarrhea, enteritis, inflammatory bowel disease, intestinal and biliary fistula, intestinal surgical resection, and pancreatitis can cause a reduce in magnesium. Hypomagnesemia can also occur due to decreased intake, like in starvation, anorexia nervosa, alcohol use disorder, and in patients who are on total parenteral nutrition. Renal losses, like with diuretics, aminoglycosides, amphotericin B, promote urinary magnesium wasting by decreasing the tubular absorption. Conditions like diabetes, hypothyroidism, hypercalcemia, and acute tubular necrosis further increase the renal excretion. Conditions that can redistribute and shift the extracellular magnesium into the intracellular compartment, like treatment of diabetic ketoacidosis by insulin, refeeding syndrome, correction of metabolic acidosis, acute pancreatitis, ethanol withdrawal syndrome, can all cause hypomagnesemia. Some drugs like proton pump inhibitor, loop diuretics, aminoglycosides, amphotericin B, digitalis can also do the same. Sepsis, trauma, burns, diabetes, inflammation, and insulin resistance can also cause hypomagnesemia. In critically ill patients, hypomagnesemia can present with arrhythmias like atrial fibrillation, polymorphic VT, muscular weakness, tremors, seizures, paresthesia, tetany, involuntary movements, apathy, delirium, or coma. In critically ill patients who are hemodynamically unstable, have cardiac arrhythmias, tetany or seizures, or have electrolyte abnormalities such as hypocalcemia or hypokalemia, are treated with IV magnesium sulfate of 1 to 2 grams, which is infused over 2 to 15 minutes. This dose can be repeated as necessary to maintain the plasma magnesium concentration of above 1 milligrams per dl. The maximum dose that can be given is 50 milliequivalents, which is given over 8 to 24 hours. In asymptomatic mild hypomagnesemia, oral magnesium is preferred. Thank you.